Azin Tavasoli, and I'm going to present an abstract of a study from the Charter Aging project by the title of Increasing Neuroinflammation Relates to Increasing Neurodegeneration in People with HIV. In vitro models of HIV neuropathogenesis show that HIV causes neuroinflammation and immune activation, and systemic inflammation and immune activation, which in turn drive neurodegeneration. Cross-sectional studies of people with HIV confirm that higher levels of biomarkers of neuroinflammation correlate with increased biomarker of neurodegeneration. A more convincing confirmation would be a longitudinal demonstration that as neuroinflammation and systemic inflammation increase, neurodegeneration does so as well. We evaluated this hypothesis in a cohort of people with HIV with repeated sampling over 12 years. People with HIV in the US multi-site Charter Aging project were assessed at a baseline visit and again after 12 years using standardized evaluations. Participants with severely confounding medical and neuropsychiatric conditions such as active psychosis were excluded. Participants were included in this analysis if their plasma HIV RNA was fewer than 50 copies at follow-up. A panel of 14 soluble biomarkers were measured, including CRP, CD40, D-dimer only in plasma, NFL, total tau, APP alpha, A-beta 42, phosphorylated tau only in CSF, interleukin-6, STNFR2, atoxo-DG, neopterin, MCP1, and CD14 in both of them. We calculated changes in each of the biomarkers from baseline to the 12-year visit. Factor analysis were used to construct simplifying indices of biomarker changes separately for biomarker of systemic inflammation, neuroinflammation, and neurodegeneration. We examined correlation of changes in systemic and neuroinflammation activation factors with changes in neurodegeneration factors. Participants were 108 ART-treated people with HIV, all virally suppressed at follow-up. They were divided into two subgroups based on changes in viral loads between the baseline and the follow-up visits, those who remained suppressed and those who became suppressed. 53 participants became suppressed and 55 participants remained suppressed. The mean age of people who became suppressed was 55, when the mean age of people who remained suppressed was 58. About 6% of people who became suppressed were female, while 22% of people who remained suppressed were female. People who became suppressed included 17 Black, 5 Hispanic, and 13 non-Hispanic white. And people who remained suppressed included 24 Black, 5 Hispanic, and 22 non-Hispanic white. The current CD4 median of both groups were 579. The median CD4 nadir in people who became suppressed was 109, while in people who remained suppressed was 67. Plasma immune factor analysis yielded two factors. Factor 1, CRP, D-dimer, and neopterin. Factor 2, STNFR2. Neurodegeneration factor analysis yielded two factors. Factor 1, p-tau, A-beta 42, and factor 2, NFL. CSF immune factor analysis yielded two factors. Factor 1, STNFR2, and neopterin. Factor 2, MCP1, CD14, and interleukin-6. In this figure shows that higher levels of CSF immune factor 1, which means change in CSF STNFR2 and neopterin, were associated with higher levels of CSF neurodegeneration factor 2 or change in CSF NFL. For those who remained suppressed, the correlation was much stronger than for those who became suppressed. Older age was associated with higher levels of many biomarkers of inflammation and neurodegeneration at baseline, especially CSF-STNFR2 and CSF-NFL. However, older age was not associated with changes in these same biomarkers. Increasing biomarkers of neuroinflammation and systemic inflammation in people with HIV were associated with corresponding increases in biomarkers of neurodegeneration, supporting the hypothesis that neuroinflammation and systemic inflammation drive neurodegeneration. These results raise the possibility that reducing neuroinflammation and systemic inflammation will slow or reverse neurodegeneration, a possibility that can be evaluated in clinical trials. Thank you for your attention.